Hello, everyone. I am Rahul Gosain,
And I'm Rohit Gosain.
and we are the Oncology Brothers. Today, we'll get a chance to focus on hepatocellular carcinoma. The leading cause of this still remains underlying cirrhosis, either from infectious etiology, such as hepatitis B or C, or from NASH. Also, we are now diagnosing HCC a lot earlier due to ongoing screening programs of ultrasound or monitoring AFB for patients with underlying cirrhosis. Depending on the stage, the treatment options vary from potential transplant to local control to systemic treatment. To unpack all this, we're joined by Dr. Tony Bekaii-saab from Mayo Clinic. Tony, the last time you were here, it was to cover your data from Mountaineer study. This time around, we have a different focus. Welcome back.
Well, thank you. Glad to be with the two of you and looking forward to a very engaging discussion.
Thanks so much, Tony. Tony, the first and foremost important thing in any cancer is multi-D discussion and, of course, a patient-centered approach. And I can't stress the importance of that, particularly in hepatocellular. That's where it's the most important, rather. Focusing on early stage setting, here's the algorithm for early stage 0 to A along with intermediate B. How do you approach these patients, though medical oncology plays less role here, but though you do take part in the tumor board discussion? So how does that discussion look like?
Yeah, so the main question, of course, at this point of time stems from two studies that have moved us a little closer again to the early stages, to the clearly resectable, to those patients who are intermediate, clearly candidates for chemo-embo or TARE in our situation. So in that sense, there are two studies, EMBRAVE 050, which did suggest that Atezolizumab in the high-risk patients, could be considered an option. And I say could be, I'll tell you why I'm thinking could be and not definitive at this point of time, could be an option for patients with high-risk HCC post-resection, high risk for relapse. And so for that subgroup of patients, Atezolizumab did improve the relapse-free survival at the median versus active surveillance. No, just very quickly, the high-risk features mean, that patients have a tumor more than 5 centimeter, more than 3 tumors, microvascular invasion, minor macrovascular invasion, so VP1, VP2, and grade 3 or grade 3/4 pathology. So these are considered high-risk features, and those features essentially led to including those patients on the study. So the reason why I said maybe considered and not definitive yet is, although the relapse-free survival looks pretty solid and favoring Atezolizumab, we don't have survival results yet. We do understand that patients get salvaged with Atezolizumab, and certainly that may blur the survival. But then, when you look at the curves, those curves collapse after 18 to 20 months, meaning that most patients end up, in parallel. Is intervening early enough with immune therapy to actually induce a survival benefit is the main question. So we're still waiting on that data, but case-by-case basis, I'm offering it to my patients today. I have that discussion as long as the insurance or the insurer does not make it more difficult than it needs to be. So the other...
Sorry,
yes,
sorry.
please.
Can you clarify that you are offering this outside clinical trial for your patients today?
Yes.
Okay.
Not for all, on a case-by-case basis.
Absolutely.
Case by case. And the reason is because, patients with high-risk disease essentially, have the highest likelihood of a recurrence. And recurrence sometimes is pretty aggressive with some of these patients, to be frank. And that prohibits us essentially to move to systemic therapy. So I feel that there is some value for select patients, case-by-case basis, in considering this for the high-risk relapse. I'm hoping that the overall survival will show at least a trend. I understand it may not be, that amazing difference just because, patients will get it on the back end. But I do believe that, there is enough data at least for us now to consider it on a case-by-case basis. And if survival is benefit, that's going to be your standard.
Right, especially in this deadly disease, though, if we can actually target cure in early stage setting, though it will murky up the data, how are we going to proceed in advanced stage? So we'll have to definitely look at that.
Yes, and we have a precedent. colon cancer.
Right.
FOLFOX, mostly disease-free survival improvement, less of an overall survival improvement. But overall, it did change the needle for most of these, for a lot of the 5%, 6% of these patients. That's a lot on top of 5FU. That's a lot of patients that we added to the checkpoint of cure box. And I do believe we're going to see this hopefully at some point once we get the survival data presented.
Again, for our listeners, this is not FDA approved. This is not standard of care yet. This is something we're just talking about on case-by-case basis. Tony, this ends up being high risk post-surgery. In early stage, another modality, of course, is transplant, though a small subset. There's been this idea that in few centers, pre-liver transplant biopsy can result in an exclusion from transplant. How strict is this particular recommendation? Because in the community settings, before even getting to a transplant center involved, is it a good idea to do a biopsy to confirm if the image is not conclusive?
Yeah, no, that's a great question. So the straight answer is, if you don't need a biopsy before you refer, don't do it. But if you do a biopsy, that doesn't exclude the patient from transplant. I mean, it's becoming less and less strict now. Yeah, it used to be truly, I mean, saying, I messed up the chances of this patient ever seeing transplant. That's not true anymore. We're much, much better in terms of selecting those patients and getting them to transplant, navigating the transplant. I would still say, though, you don't necessarily need a biopsy to confirm before you consider, early intervention, transplant or resection. So I think that you're safe. And a lot of the radiologists have become quite a bit in tune. Our scans, our MRIs have become so much better that we're able to classify those tumors based on, LIRAD scoring about the risk. Even, my radiologist can tell me, if there's a potential cholangiocarcinoma component now just by looking at the scan. And again, that's not necessarily the case for, everywhere. But know that if there is suspicion, you don't necessarily need a biopsy. If you feel like you really need a biopsy for, a reason that are, to your discretion, ultimately, the physician is responsible for their patients. Then you shouldn't be concerned about missing on an opportunity for transplant if transplant isn't an option.
Absolutely.
Right. How important this is because you're targeting a curative intent approach, especially in this deadly disease. So though that is a small subset, but we should not miss out on this opportunity. Now, if transplant and surgery is not an option, then we are left with localized therapy, mainly ablation, Y90, TACE, or SBRT. Now, I do acknowledge that you're not a radiation oncologist or interventional radiologist. Tony, how does that conversation look like, especially from MedOnc standpoint, from community? We need to know when should we be utilizing our friends here from radiation oncology and IR, and how do these modalities differ, or when do you utilize them?
Yeah, no, I mean, and again, this goes back to the multidisciplinary discussion. So, the interventional radiologist, has become our friend across the board, frankly, through all the stages.
Right.
Even for patients, who may be transplant candidates, but need to have the waiting period, we're using TARE for some patients, to control the tumor in waiting. We also have used, for those intermediate stage patients, mostly TARE, and I'm focusing on transarterial radioembolization because we've almost moved completely from chemoembolization, from transarterial chemoembolization. And I can tell you, I mean, in actual practice, man, I used to dread TACE. I'd see that patient, they're fatigued. They take 2 to 3 months to recover. They're not, I mean, once they recover and if the disease is under control, they do great. But those 3 months are miserable. With TARE, it's a different story. Those patients, are coming to us, they're fresh, they're strong, they're ready. And so with TARE, you also can focus, higher dose radiation from what I understand from my interventional radiologist, with segmental approach rather than just blast, a whole lobe. So there's a lot of ways where TARE has become very useful. So in that sense, we've actually, started talk about, again, reverse reverse migration. Actually, it's a two-way migration for intervention radiologists moving up to the early stages, but also for some patients even moving to the more advanced disease. So instead of chemoembolization, we're actually mostly doing transanterior radioembolization, and that's where our patients are ending up mostly at that intermediate stage. Now, intermediate stage also is not clear cut, so there's intermediate stage that's less intermediate and more intermediate, just to make it more confusing, right? But those that would be more eligible for systemic therapies, and then perhaps, go back to TER, and those that are, more, along the lines of local regional, closer to the earlier stages. So all this to say that there is no black and white. It's all gray, frankly. And that's actually not a bad thing. That's a good thing for our patients. But that's why it's also important to have everyone at the table discussing the care of our patients at every time we see those patients. Very important and key for success.
Tony, thanks for going over that. This is complicated. Again, like you've mentioned, it's not black and white. Talking about the gray zone, this is where we also saw some study data at GI ASCO 2024, Emerald-1. So again, that was disease confined in the liver, unresectable. When I'm talking about Emerald-1, we also have breast cancer Emerald trial that led to approval of elacestrant, but here Emerald-1 in HCC is looking at TACE, with durvalumab and bevacizumab. Briefly, Tony, your thoughts, and are you using this already outside clinical trial in your practice? I know you've mentioned IMbrave 050 as an option. What about here?
Yeah, we're still digesting this one, to be frank with you. Although, one of the main reasons is this was with TACE, and TACE is not our standard. There's a study that's Emerald TER, that's undergoing, and that will actually explore the very similar question, not this large study, a smaller study, but trying to reproduce the results, mostly concerned about the safety piece, with immune therapy and TER. There is quite a bit of rationale to consider TER, with immune therapy, in terms of how it works with immune milieu versus TACE. It seems to essentially be much more, I'm going to use the word, energizing for the immune milieu, and makes immune therapy, more effective, at least on a theoretical basis. So it's exciting to see that. So, we're still somewhat digesting the data, although it's tempting. And I would say that it's tempting enough that we may start considering it. We're starting to introduce the concept with our, multidisciplinary group, and I think, I'm starting to see some acceptance about moving for select patients where we believe that we need a little bit more of a push to get those patients perhaps into the zone of resection or maybe even transplant.
Again, here, I think overall survival is going to be critical. This is also not approved yet. Coming back to what's approved, if the disease was to progress, or if we were to diagnose advanced stage disease. Tony, your thoughts on first line and then moving on to second line?
Yeah, so first line is maybe a little bit easier to discuss than second line, just because of how the landscape, evolved. But so let's think about two buckets: immune therapy and non-immune therapy based regimens. So predominantly, most of your patients are going to get immune therapy if they're Child-Pugh A. We'll talk a little bit about Child-Pugh B. When we think about the non-immune therapy, so it's lenvatinib or sorafenib. Sorafenib, unfortunately, has fallen out of favor, mostly because of the toxicity profile. Lenvatinib, a little bit more tolerable. I mean, it has its own set of issues, but overall, is an option that would be favored in that sense. Now, the only time you're going to consider, well, there are three reasons why you would consider not using IO. One is solid organ transplant, although again there are nuances around here. We have a clinical protocol at Mayo Clinic now allowing these patients with very close observation and working with hepatology. I don't recommend it, by the way, to be done outside the confines of a large center on clinical protocol, because you can lose organs in 30-40% of the patients if not done right, and it's the devastating outcome. Also, patients with severe autoimmune disease, uncontrolled. That doesn't mean I haven't treated the patient with ulcerative colitis or with Hashimoto's thyroiditis. I have with, you make the endocrinologist your best friend, and they'll treat you well and treat your patient well. And then the third, of course, is patient preference. I mean, we all have rural patients from rural areas. They just don't want to come for the IV, even every 3 or 6 weeks. They want to take their oral drug, and, the nurse, the first month, they'll come. And after that, once they go on cruise control, they just don't want to deal with us except every 3 to 4 months. Understandable, right? We're not curing necessarily this cancer, but those are the patients. So most of your patients will have IO. We have 2 options, Atezolizumab and Durvalumab. How do you pick between those 2? The problem is they were never compared head to head. Big differentiator between the 2 is Atezolizumab was looked at in patients, including those with VP4 involvement, so main portal venous thrombosis. Durvalumab, on the other hand, did not. The other difference is Atezolizumab was looked at in a setting where patients underwent upper endoscopies within 6 months to essentially address varices if present. I think a common misconception is that if you if they found a varix that's grade 2+, the patient was excluded. They were not. As long as it was addressed, they went on the study. Durvalumab did not, but Durvalumab also did not include data on. I mean, we don't know. Some patients may have underwent EGDs, so it's difficult to tell. But there are differences between the 2. The 2 things about these studies, Atezolizumab essentially versus placebo, performed well on all its endpoints. 2 co-primaries, OS/PFS, and did well on all response. Durvalumab, on the other hand, did not perform well on PFS. They were negative, but their primary endpoint of OS was positive. And the separation seems to happen a little bit at the way beyond progression. So it is, and we all hear about landmark analysis and all this, but the reality is none of these studies were ever powered for a landmark. I don't know what a landmark analysis is. Now this is like a new term that comes out, right? It's like suddenly now I'm going to tell you about what 3 years from now happens to these patients, but disregard what happens at the median. Well, you can't do that. You're powered for a certain element. This is an observation. It's very promising, but I cannot just go based on that. So today in my clinic, most patients will go on Atezolizumab, and few select patients. Let's say a patient who had a heart attack 2 months before enrollment, or I hear sometimes questions about, well, how about those patients who are at high risk for bleeding? Well, guess what? Those are the patients who have a poor performance status, typically Child-Pugh score that's higher. And those are the patients that essentially never entered into these studies, one or the other. So I don't know. I mean, I don't frankly know who those patients are, at least those that typically qualify. The other thing that's important to keep in mind, when you say Child-Pugh A and B, I would be very cautious about B. B7, good performance status, is an A in my viewpoint. Treat them exactly the same. When you start going above B7, you're starting to tread very risky territory. The patients don't do as well. And Child-Pugh B9 is almost a C. And I actually avoid treating those patients. Those are the patients I would categorize mostly in best supportive care. And for Child-Pugh B8 plus, with a performance status that's good, the question is does IO play a role there? Versus a TKI. And if I would use an IO, I would favor single agent Durvalumab for those patients, where the data, at least for Child-Pugh A, seems to be reasonable. We have data with Nivo in B7, single arm study, looked relatively reasonable. The data with sorafenib in Child-Pugh B patients comes mostly from the Gideon study, all study, that was observational. Wasn't really a prospective study, was observational, but did show that you lose quick benefit, as you move to B. And there were some Cs, and the Cs, had an OS of less than 2 months. And so very careful about, how we look at the B. Not all Bs are the same. Performance status is very important. And just to finish this off, in the second line setting, the problem is all these studies listed, Nivo, Pembro, Rego, Cabozantinib, Ramucirumab, AFP more equal than 400. Those studies were all done in the setting of failure of prior sorafenib. So it makes it very difficult to understand how these would fit beyond IO. The other question that always comes about, well, can I use lenvatinib in the second line when I use IO in the first line? The answer is possible, but there's not much, right? There's not much data for lenvatinib in the second line. And so it's guess game. And if you use Atezolizumab, talk about, a very potent VEGF inhibitor, lenvatinib, post-Beva, I'm not sure that that's going to cut it. So my preference would be for Cabo or Rego post-Atezolizumab. For Durva-Tremi, I think I could consider RAM or even lenvatinib because that patient hasn't seen a VEGF inhibitor, or Rego-Cabo for that matter. So it's a little bit more open in that sense. And if you go on lenvatinib, I think your second line could be anything. It could be dual IO if you still have a fantastic performance status, or it could be single agent IO, for borderline performance status.
Wow, thank you so much for covering, Tony. That was quite a bit to unpack there, and thank you so much for doing such a remarkable job. Now, to reiterate that bevacizumab-based regimen, you do need EGD to rule out concerns of varices, and as Tony stressed, that does not preclude you from getting the therapy, they just have to be addressed. Now, Atezolizumab versus Durva-Tremi. Both of these studies did include Child-Pugh A patients, not Child-Pugh B7, but we can still extrapolate some of this data and apply that to, since it's early Child-Pugh B. But again, 8 and 9, definitely take caution and consider best supportive care. Now, Tony, talking about the side effect profile, any particular clinical pearls that you would recommend here itself that rather are new that us as community oncologists should be very much aware about?
Well, I think, when you look at all these agents, other than just dual IO, anything that hits VEGF, whether it's sorafenib, lenvatinib, regorafenib, cabozantinib, ramucirumab, I mean, you name it, has the potential to increase the risk of bleeding. And, for those patients, again, there will be well selected, specifically, consideration for a screening upper endoscopy, I think is very important for all these patients. So we always focus on bevacizumab, and one of the key aspects of bevacizumab, it's a longer half-life, which is the same for ramucirumab. But the reality is, once you see a bleed, it's a bleed. And with sorafenib, I've seen some of the most disastrous bleeds, not just from the varices, but I've had patients with wound dehiscence. I've had, issues with a lot of different, issues that are related to VEGF. On the other hand, when we think about, dual IO, we're amplifying essentially the immune-related toxicities. We know that on that study, about 1 out of 5 patients actually ended up with high-dose steroids. So we know that, even though, Tremi was given as a single dose, but it was given at a high dose, so that what they called, an induction dose or priming dose, whatever sounds, sexier. I guess priming sounds like, wow, but that priming dose was a high dose, and you still seen 1 out of 5 patients, that needed high dose steroids. So I think, selecting the right patient, I mean, that's key.
Perfectly summarized, Tony. Thank you so much for taking the time to cover this particular algorithm for treating HCC in our community and academic setting. For our listeners, let us go over a quick recap. In this discussion, we covered the current treatment landscape for hepatocellular carcinoma with Dr. Bekaii-saab from the Mayo Clinic. For early stage, it is important to consider liver transplant if this is in fact a viable option. If not, then exploring local therapy, including Y90, SBRT, or ablation, should be considered.
For advanced or metastatic disease, we had a chance to discuss options including Atezo with Bevacizumab or dual checkpoint inhibitors based off STRIDE regimen. When are you going to favor one regimen over the other in your practice.
And last, we also covered treatment options beyond frontline and some clinical pearls around management of these available TKIs. Thank you for joining us. Make sure to check out our colon cancer and upper GI algorithm discussion as well. We are the Oncology Brothers.